Relapsing remitting multiple sclerosis is a chronic autoimmune disease where the body's immune system mistakenly identifies and attacks its own central nervous system. This medical illustration contrasts a healthy neuron with a nerve affected by MS. The disease destroys the myelin, the insulation that allows nerve impulses to travel efficiently. When that myelin is gone, it leaves an exposed fiber and leads to permanent physical decline. The central challenge in treatment is that current therapies cannot repair this existing damage or restore lost function. They can only prevent new lesions from forming in the first place. Because of that, patients must navigate over 20 FDA-approved disease-modifying therapies, each with vastly different strengths and safety concerns. It creates a difficult choice. Do you risk the severe, immediate side effects of the most aggressive drugs? Or do you risk the irreversible nerve damage that often happens when a weaker drug isn't enough? The traditional approach is called the escalation strategy. You start with safe, low-efficacy medications and only step up to stronger drugs if you suffer a breakthrough relapse. The modern alternative is the early, high-efficacy strategy. Instead of waiting for a relapse, you hit the disease with the strongest immune-depleting drugs immediately upon diagnosis. A real-world test of these methods compared the Czech registry, which uses low efficacy first, with the Swedish registry, which favors high-efficacy drugs from the start. This chart reveals the difference. Swedish patients, using the early aggressive approach, saw a 66% reduction in relapse risk compared to the Czech group. That protection improved long-term mobility, giving the Swedish group a 26% lower risk of disability progression. Registry data showed that patients switch off low-efficacy drugs because those drugs fail to stop the disease, not because patients couldn't handle the side effects. This evidence suggests that the safe path of starting with weaker drugs often results in worse physical outcomes. It's forcing a reconsideration of how we define medical risk in MS. To make sense of these options, the American Academy of Neurology guidelines provide a framework for evaluating a drug's efficacy against its daily lifestyle burden. This table focuses on Tier 1, low-efficacy therapies like interferon beta and glutathione acetate. These injectables offer a predictable safety profile without deep immunosuppression. The trade-off? Flu-like symptoms and the highest risk of new brain lesions. Tier 2 covers medium-efficacy oral therapies like teriflunomide. Here, you swap injections for the convenience of a daily pill. These medications generally offer better relapse control than Tier 1 injectables, but the risks increase. These require regular lab monitoring, pose serious dangers during pregnancy, and carry a rare but fatal risk of a brain infection called PML. There is also a biological danger if certain pills are stopped abruptly. Discontinuing them can lead to a severe rebound of MS activity. While Tiers 1 and 2 prioritize logistical convenience and baseline immune safety, they can leave the central nervous system vulnerable to silent progressive damage. Tier 3 represents high-efficacy therapies, specifically anti-CD20 monoclonal antibodies like ocrelizumab or rituximab. These work through an aggressive biological mechanism, intentionally wiping out the body's B cells to reach a state called NETA, no evidence of disease activity. Logistically, this means trading daily kills or weekly shots for an intravenous infusion at a hospital just twice a year. The primary trade-off is deep, systemic immunosuppression. By clearing out those B cells, these drugs make the patient highly vulnerable to severe respiratory and urinary tract infections. This path also carries a massive administrative burden. It requires mandatory monitoring programs, demands regular blood work, and lifelong clinical compliance for safety. High-efficacy drugs offer the best statistical chance to permanently stop MS in its tracks, but they demand a lifestyle shift centered around infection awareness and frequent medical check-ins. Choosing a therapy isn't just a medical calculation. It's a personal assessment of what you can live with day to day. A risk-averse patient might choose low or medium efficacy to protect their immediate immune function and avoid the logistical burden of hospital infusions. This flowchart illustrates the clinical cost for that profile. To stay safe on a weaker drug, you must undergo vigilant, regular MRI monitoring to catch silent nerve damage before it becomes permanent. An optimizer profile describes patients willing to accept the infection risks and the infusion schedule if it guarantees them the best possible chance of staying mobile for decades. There is no perfect choice. You are essentially choosing whether to sacrifice the full strength of your immune system or sacrifice maximum protection for your brain and spinal cord. It's also important to recognize that standardized rules for efficacy don't always apply to every patient equally. Clinical data shows that Black patients often experience faster B-cell repletion and have a significantly lower protective response to standard interferon therapies. Because of this, Black patients are at a disadvantage with the traditional escalation approach and should advocate for high-efficacy therapies immediately upon diagnosis. Age is another factor. For patients over 60 who have been stable for years, the safest choice may actually be discontinuing treatment entirely to remove the burden of side effects. Ultimately, managing multiple sclerosis is a collaborative process. It's about taking the clinical data and mapping it onto the realities of your age, your demographics, and your daily life.